All right, I might make a start, just wanting to get started on time because we do have quite a bit of content to get through, and want to make sure that everyone has enough time to say what they would like to and to encourage some conversation, but also that we can leave promptly at 8:30 as well. So welcome everyone and thank you for joining us this evening. My name is Sarah Lorimer, my pronouns are she and her, and I work as a sexual and reproductive health coordinator at GenWest. And along with Tilly from Women's Health in the North, we've coordinated this session, which we're very excited about because it's been quite a few months in the making, years even, but because of the pandemic, there has been a little bit of disruption. So we haven't been able to hold one of these education sessions for a couple of years now, but we're very glad to be able to do that and to have joining us this evening, Carolyn from 1-800-MY-OPTIONS, Dr. Linda Rose Topiyama from Clinic 66, Trish Hayes from Melbourne Pregnancy Counsellors, as well as Dr. Patty Moore and Kath Hannon from the Royal Women's. So thank you everyone. It's really important that we're having such a great turnout today. The education and ongoing support for healthcare professionals is really an essential step in the improvement of abortion access in Victoria and across the country. The recent events in the States are a reminder that we can't take access to reproductive health rights for granted, and it's an important opportunity for us to reflect on the access provided to pregnant people in Australia, and to consider that our work and the way that we approach things is really impactful, and that it's essential that abortion access is timely, it's affordable, it's accessible regardless of where people are located, and that this healthcare is provided by informed, trained health professionals without stigma or judgment. But before we get into tonight's proceedings, I would like to acknowledge the country that we're all meeting on today. I do believe that is different country, but I would like to recognise that the land on which we work and provide our services always was and always will be Aboriginal land. We pay our respects to elders past, present and emerging, and proudly acknowledge the Aboriginal and Torres Strait Islander communities across Melbourne's northwest, their rich cultures, diversity, histories and knowledge, and the deep contribution they make to the life of this region. So I just want to give a bit of a session overview of how this evening will look. We'll start with a presentation from Carolyn from 1-800-MY-OPTIONS, followed by Trish Hayes from Melbourne Pregnancy Counsellors, and there'll be a joint presentation from Dr. Patty Moore from the Royal Women's, as well as Dr. Linda Topiyama, a local GP. Kath Hannon, Tilly and myself will then be providing a bit of information about the Clinical Champions Project, referral pathways and resources that will support you in becoming a provider. And at the end of the evening, we'll be able to answer all the questions that you have in the Q&A session. And then we'll just wrap up with a brief but very important evaluation session. So just a little bit of housekeeping before I pass over to Tilly. Just to let everyone know, this session is being recorded. It is a webinar format though, so all that will be recorded is the presenter and their slides at the time. Everyone will be muted, so if you do have questions, please pop them into the Q&A box. That's rather than the chat box. If you could pop them into the Q&A box, that would be great, and we'll go through those in the Q&A session. Also to GPs in attendance tonight, please ensure that your Zoom name is the name that you registered with, just so that the PHN can mark you down for your CPD points. All right, thank you. I'll pass you over to Tilly.
Hi everyone, thank you for coming along. As Sarah said, I'm Tilly. I'm the coordinator for sexual and reproductive health at Women's Health in the North. So a little bit about GenWest and Women's Health in the North. We're both organisations working to promote gender equity, and a key aspect of that work is sexual and reproductive health promotion. So our work in that space includes providing health education to communities in the north and west corridors of Melbourne, and advocating for sexual and reproductive health and rights. We do this by working with many partners across our regions, and that includes other women's health services across the state, and people from community health, local government and health services. So we're involved today because, as Sarah said, abortion is legal here, but there remains limited access to medical abortion across the state. So we've partnered with the Royal Women's Hospital and Northwest Melbourne PHN to deliver this professional development session to health professionals across the northwest region of Melbourne. In developing this session, we created a working group with local GPs, pregnancy counsellors and sexual and reproductive health nurses to develop the key learning objectives. And we are very lucky to have some of these people here tonight speaking. So first up, I would like to introduce Carolyn. Carolyn is the manager of 1-800 My Options. Welcome, Carolyn.
Thank you so much, Tilly, and thanks to yourself and Sarah and Northwest Melbourne PHN for involving 1-800 My Options in this event. We're really excited to be here and talk to GPs and other primary healthcare professionals about what we do and how we can support you in your work. So 1-800 My Options is a service of Women's Health Victoria. And we do also acknowledge and pay our respects to the traditional custodians of the lands on which we're meeting. Today I'm on Wurundjeri land. And as a statewide organisation, we acknowledge the traditional custodians of the lands and waters across Victoria and pay respects to them, their culture and elders past and present, recognising that sovereignty was never ceded and that we're beneficiaries of stolen land and dispossession, which began over 200 years ago and continues today. Thank you. So 1-800 My Options is a multifaceted service, and we are a phone line first and foremost, operating 9 to 5, Monday to Friday, and we're funded by the state government to be a pro-choice, non-judgmental service for people who want to call up asking about contraception, pregnancy options including abortion, and sexual health. We provide non-clinical information to our callers and pathways to services that are going to meet their needs. So we may have callers that are calling asking about abortion services for themselves or for their friends, their partners, their family members, or their patients or clients. We also have a website which includes evidence-based sexual and reproductive health information and links to trusted information sources as well. And the website also has a geomapped database of sexual and reproductive healthcare service providers across the state. It's mapped and you can filter for services or area on the map. So you can look at Northcote and see who is providing medical abortions there. You can look at Melton and see who's providing hormonal IUDs in that area. If you're looking for them for yourselves or you're looking for them for your patients or clients. 1-800 My Options also does health promotion, support and advocacy across the sexual and reproductive health system in Victoria. Thanks, Tilly. So when somebody calls 1-800 My Options, it doesn't really matter who they are. We're going to see what we can do to find the services that can actually meet their needs. We do a really brief assessment. So where they're looking for services, what kind of services that they require, and this is an area where there's a lot of education going on the phone line. Often somebody's looking for an abortion. They're not quite sure what's available for them, what's appropriate for them. There's a lot of myths around abortion, and we try to work with people to provide them with the evidence so that they can make the choice that's best for them. We always ask our callers if they've made contact with the GP, because obviously if they've had any kind of workup, then that's a really useful bit of information for them. And they also need to know that some workup will be required. A bit of demographic information, so things like healthcare card, Medicare card, whether they've got any supports in place, ethnicity or Aboriginality, and any other information that might impact on a referral that we might make. Generally, we'll give our callers at least 3 places that they can reach out to. We're always impartial and non-biased about which clinics we're going to give somebody, because we want to make sure that we're spreading the load across the entire system. We give the callers the address, phone number, opening hours if that's what they need. But we also have specific referral pathways for people who meet quite clear criteria. to the Women's Hospital and Sexual Health Victoria. Thanks, Tilly. So I'm not sure that this map will work for us right now. Tilly, do you reckon you can click on that and see if we can get it to function? I should have checked this beforehand. Oh, there we are. So this is the 1-800 My Options website, and at the very top, you can click on Find a Service for sexual and reproductive health and go down a little bit and search for healthcare services. And it comes up with this fabulous map of Victoria. On the public version of our map, we have 387 providers listed. On the private version of our map, which is only visible to our phone operators, and we give details of clinics that are on the private version to our callers when and if it's appropriate. On the private version, we have over 450 providers. So there's about 85% of our providers are publicly listed. So you can search by suburb or postcode. You can filter for types of abortion, types of contraception, types of providers, and ensure that you're actually finding services that meet all your patients' needs, where and when they want to have them. Thanks so much, Tilly. You can probably skip back to the slideshow now if that's possible. Oh, amazing. So we've recently, as part of Women's Health Victoria's work, we have a service called the Victorian Women's Health Atlas, and this looks at disaggregated data across the state by LGA, so by local government area, and it looks at various health indicators that we want to know about, and we want to see how they're performing in relation to women's health. You can look at a lot of different indicators, things such as STI notifications, suicide and self-harm. You can look at cancer, family violence, and various other health indicators like that. And we've recently published an indicator for medical termination of pregnancy services received by women aged 12 to 54 across every LGA in Victoria. And what it shows us on the Victorian Women's Health Atlas is the number of services received by people in any given LGA, the number of services prescribed in any given LGA, and the number of services dispensed by pharmacists in any LGA. So statewide, we know that there's around about 4.57 Mtop services received by women per 1,000 women of reproductive age. That's the statewide average. We estimate that that's probably an underestimate because not everyone who's actually wanting to get a medical abortion is able to for a variety of reasons. So we know that there's some differences between the statewide average and north and west. So in the northern region, we know that it's about 4.3 Mtop services per 1,000 women of reproductive age across the region, but it ranges from 3.38, which is quite significantly below the average, up to 5.9. In the western region, we've got an average of 4.6, so pretty similar to the state average, but again, it ranges from 2.3 Mtop services received by women up to 9.6. So it's quite significant. And statewide, we also know that in 53% of all Victorian LGAs, fewer than half of the Mtop services received by patients were actually prescribed from within that LGA. That means that people are having to travel. And for the Northern Metro region, about 5 out of 7 LGAs had fewer than half of Mtop services received by patients being prescribed from within that LGA. Western Metro region, 2 out of the 7 LGAs had fewer than half of the Mtop services received by patients prescribed within the LGA. You can explore that data a little bit more deeply to look at the LGA that you're in on the Women's Health Atlas website. Move along now, Tilly. So in terms of how we can work with you, I'd really encourage GPs, primary healthcare providers to consider sexual and reproductive health service provision, meeting the needs of the community of your patients. You can all register your services on the 1-800 My Options website. There's a link for health professionals there, and we will provide your details to callers as and when it's appropriate for them. So whether those services that you provide are medical abortion or IUD, implant-on, cervical screening, these are all things that we register on the website. You can also contact us if you've got a patient that is looking for any kind of sexual and reproductive health service that's not provided in your clinic. You can give us a call and we'll help you figure out which services in the local area might suit their needs. And you can also promote 1-800 My Options in your community. We have a number of resources, posters, stickers and cards and brochures that you can display in clinics or other community areas to promote sexual and reproductive health towards aiming for really great sexual and reproductive health outcomes in your community. Thanks, and that's my contact details, but I'll stick around for the rest of the session in case anyone has any specific questions. Thanks so much, Lee.
Thanks, Carolyn, and my apologies for the slide mishap just then. Now I would love to introduce Trish Hayes. Trish is a mental health social worker and counsellor at Melbourne Pregnancy Counsellors. Welcome, Trish.
Thanks, Tilly, and thanks to everyone for putting on this evening. It's really great to see the timely issue of early medication abortion and this training being put on for GPs and other primary providers. So I know I've got 20 minutes. Tilly, feel free to prompt me close to the end because I really can bang on a little bit. And it is quite a juicy topic that I could speak for a long time about, but tonight I've tried to distill some of the important information I think that early medication abortion providers might need to think about when working with women and pregnant people who are seeking either pregnancy options, information and or have made a decision for early medication abortion. So just briefly, I work in private practice as a counsellor with Melbourne Pregnancy Counsellors, but have worked, actually it's 20 years this year, have worked in abortion, pregnancy options, counselling space at Royal Women's Murray Stopes and now in private practice. So I thought I'd just start by acknowledging that often the journey will start with Carolyn's team at 1-800 My Options. So we Melbourne Pregnancy Counsellors is a network of 4 colleagues, and we tend to get quite a few referrals from 1-800 My Options of women and pregnant people who are seeking further information, support, counselling advice around their unplanned or unwanted or unintended pregnancy. We also get referrals from GPs in the area who know us, and word of mouth through lots of different social services as well. So I'll start with what is abortion and pregnancy options counselling. Well, as you probably know, counselling is part of a holistic wraparound care for women and pregnant people seeking medication or surgical abortion. In a nutshell, counselling allows someone to have a non-judgmental safe space to work through their feelings, thoughts, behaviours, reactions in relation to their unintended pregnancy. We see women and pregnant people at any end of the spectrum. Sometimes they've made a decision. Sometimes they come to us for pregnancy options, really not knowing which decision to make out of continuing the pregnancy, termination of pregnancy, and very rarely adoption. Sometimes they've made a decision for an abortion but want to talk through their mixed feelings about that decision. And sometimes often we see women for post-abortion if it's needed. What we know usually is with very, very good pre-counselling support, the chances of women sort of presenting for post-abortion counselling is quite reduced. We know that the quality of the interventions before having an abortion, really, really do have an impact then on even if post-abortion counselling is needed. So the principles we use in this is, of course, we're pro-choice, which means that we're not driving women towards any of the particular options, but we do see abortion as an absolutely valid option for women and pregnant people. The principles we subscribe to is that it is entirely the woman and pregnant person's decision. Their final decision around what they do lies with them, and so that's the principle of autonomy. We're trauma informed, which means we understand the impact of the huge stats in our society around the number of women and pregnant people who would have experienced past or current interpersonal, familial, domestic or family violence and sexual violence. And culturally safe, meaning that we know that abortion decisions or pregnancy options decisions around maternity, reproduction don't happen as if the person's in a vacuum. They have a whole set of historical, cultural, socio-political circumstances that are impacting on what meaning they make and what meaning their family and community makes out of abortion and the other options. As I've said already, not every woman, pregnant person will need counselling. In fact, most people don't. Majority of people make decisions on their own or with friends and family support, so we're not needed that often. But for some women and pregnant people, it's really important. And we also know, as I said, that most women experience relief post-abortion, but there is a small minority of women who will need support to work through their feelings post-abortion. So I can't say this one loudly enough. And in fact, I finished these slides last week, and on the Tuesday and on the Wednesday, I had a referral for a counselling for a woman who was in the middle of early medication abortion. So she had already taken mifepristone the night before and was quite distressed the next morning, wondering if she'd made the right decision. That's obviously not the ideal circumstance in which to do options counselling. And of course, we worked with her around referring her back to her provider as well to talk through the implications of that. But my message in this slide is, if you, in your consultation, sense, assess ambivalence, you can't force a woman to have counselling or a pregnant person, but would really strongly suggest to that person that if they don't have anyone else to talk to, that professional counselling support by a pro-choice counsellor is really important. As I said previously, it's much more effective to have, options abortion counselling rather than it being post-abortion counselling, or indeed it being, in the case of early medication abortion, during, after they've taken the first tablet. Counselling, pro-choice counselling is really important in the sense that there are, and I'll talk a little bit more about this later, but there are false advertisers out there who say that they do pregnancy options counselling, all options, but actually they're church-based, religious-based or anti-choice counsellors. I would always say, if GPs or women don't know the credentials or the expertise, try 1-800 My Options, because they will have assessed and vetted all the counsellors they have on their database to be pro-choice. Just to go back one little moment, the counselling referral, to get a Medicare rebate for a social worker such as ourselves at Melbourne Pregnancy Counsellors, it's item number 81005, and patients will receive about half the cost back. So it's about $68, I think they'll get back, and our fees are generally around $130. Sometimes we can bulk bill in certain circumstances. All right, I asked my three colleagues just for a little bit of feedback around what might you want to tell some GPs if you got the chance in a training session to talk about what feedback you've had from women and pregnant people who've taken early medication abortion and perhaps bounce back to us for counselling. I really want to stress that this is probably a skewed sample, because obviously we're seeing women where it's been a difficult experience during medication abortion and or the experience of being pregnant and terminating. That has been a difficult decision or complex decision. So this is a skewed sample, but it's just, I guess, something to think about when you're going through what types of abortion might be available for a woman. I'm certainly not suggesting that early medication abortion is always traumatic, although you'll see that word pop up a little bit here. But I think it's good for women who are iffy, or just all women, to have options of information about, is surgical or is early medication abortion the right one for me? So some of my colleagues said things like EMA, women had said, look, whether they've had a past trauma experience, early medication abortion can be, but not always, difficult. Equally, surgical abortion for some women with a past trauma experience can be difficult. So I think my message and our message is you just need to take women through the options and let them decide as best they can themselves. Well, which option do you think is going to make you feel like you've got more control over those, those trauma feelings that are coming up for you? Is it surgical? Is it being anaesthetised and asleep? Or is it medical, where you're going to be awake and self-managing? As you can see, my colleagues have said things. Think about, if the woman has a particularly complex set of circumstances, is early medication abortion herself? She's on her own, she's in a violent relationship, she's got no support, she's got kids that she has to look after, no reprieve. Is it worth thinking about, does she need to be referred to Royal Women's or somewhere else, a public hospital, if she does want to take early medication abortion, just so she has some extra support around case managing her situation. My other colleague Chanel said that sometimes, again, it can be traumatic in the sense of some women feel ill-prepared for the visceral kind of somatic experience of bleeding, pain management, all the self-managing aspects of managing your own early medication abortion miscarriage, that some women do seem that they've been unprepared for the situation. And, again, it's going to interact with their experiences, the level of support they've got around them, their own health literacy around the issue, their feelings of autonomy around their body. But they can report it as it's that they kind of panicked and went into shock when they had to self-manage. So just really important, I guess, in that sense, as you would with surgical abortion, is just going through what the process would look like, just so the woman, has been able to think through quite clearly, okay, is that the option that I think that I can manage best? Again, Suzanne's also said, for some women, the issues of pain tolerance and a pain tolerance and management plan can be really significant. So not underestimating, the importance of going through that with a woman or pregnant person. There's a lot of wider abortion-specific counselling issues that, of course, I don't have time to go into, but I thought I'd just sort of drill down on some of the specific counselling issues. And again, I'm going to go across some ground that I probably already have in the other slides. But just to reiterate, important for the GP to discuss with the woman or pregnant person what that process will look like when she or they are at home, and just getting her to assess again, that principle of autonomy. How are these factors going to impact you? They can be both positive and negative for some women, and some women I see will say, oh my God, I really want to have control. So I want medication abortion. I want to be awake. I want to be there. And for some women who you think might have that reaction, might have the same trauma history, will go, oh God, no, take me to a clinic. I want it over and done within half a day, and I want to be knocked out. So some factors, just thinking through in that assessment with her, some of the psychosocial issues, such as, again, history of grief and loss she might have, particularly around reproductive events, previous miscarriages, IVF, any of those, or previous abortions, how that's impacting on this decision this time for what method of abortion. Again, going through her visceral or not response to how she manages pain and bleeding, making sure she knows she will have to do some of that herself, and citing the pregnancy sac, all that kind of nitty-gritty stuff can be important for some women. I just think they haven't actually thought that through so much because they've been managing the whole decision, let alone the kind of clinical side of it. Again, if you're getting a sense, or she's telling you, or her, that there's some history of trauma, again, just working through both options with her and what's going to suit her best. Again, current violence and abuse, who's going to help her on the day? Does she have to try and cover this up? Has she only got a block of one day that the perpetrator's not going to be around? All of those kind of stuff. Practical and emotional support, who's going to be around there? Childcare. There's some of the major issues, I think, that are important to go through with her. I'm just going to highlight this tool. And I'm sure the women's has probably got an up-to-date one. I'm sorry, I didn't have a good look, but this is one that's on Murray Stopes' website, which is just a great comparison chart that lay people like me use with women sometimes, when they might have made their decision. And then I said to them, okay, so where are you going to book? Do you know where you're going to book? What method? And I point them, or if there's time in the session, we'll go through surgical and medical abortion and which one they're getting a sense of at that stage which way they might lean. As I said, the surgical abortion is still valid for women where early medication abortion isn't. I know I haven't got much time. There's a couple of issues I wanted to highlight because I think that they're common issues that can come up in this sort of counselling around women and pregnant people. So reproductive coercion may or may not be a new term for some of you, but basically, as you can see, it's reproductive coercion and abuse. The definition is a behaviour aimed at establishing power and control by interfering with a pregnant person's autonomy, interfering with their decision-making and access to their reproductive health and choices. So it can show up through pregnancy pressure. So someone saying, my mum, my uncle, my partner is actually telling me to have a termination and I don't want to. Okay, so that's pregnancy pressure. Pregnancy pressure is sometimes the pressure to become pregnant or to stay pregnant. It can be around controlling your decision around continuing or terminating pregnancy and hiding, removing or throwing away contraception. Again, I'm not going to have time to go into this tonight, but the next slide, I think, will take you through, I guess, ways to check in about that. What I would say is look for congruent and non-congruent verbal behaviour. So she's saying, just put me in, minimal discussion about it. It might just be that she's guarding her privacy. It can also be that she's feeling pressured into the abortion. She is not, she's not a willing participant in the abortion, and that if you asked some more questions, you might get a better sense from her of how you might assist her in that situation. What I've put here, and I think you'll be able to access these slides afterwards, is what we call sensitive inquiry for issues of violence, abuse, sexual assault and reproductive coercion. These are just some, and this is from the Women's Strengthening Hospital Responses to Family Violence. These are just some ways to think about having those difficult conversations with women and pregnant people if you're kind of picking up some cues that there may be some abuse, pressure, coercion there. So you don't need to screen every woman and pregnant person with this, but if you're getting some of those cues, you might, provide that sort of lead-in statement saying, in this clinic, I have seen a lot of women in the situation where there's violence or abuse, and it certainly can affect their decision around pregnancy or abortion. How are things at home for you? Are you feeling safe at home? Are you frightened of anyone at home? Do you feel safe to go home or when you leave here? Anything we can help you with now? I've put some suggestions here for early medication abortion specific. So will your partner or family help you with the process? Do you feel any pressure about having medication abortion or abortion from your partner or family? And also one around, for some women, having a gynae procedure such as an abortion can trigger feelings of past trauma. Is anything like that happening for you now? So just some ideas of way to start having those conversations. You don't need to solve it on the spot. You don't need to be a psychotherapist, but you just know enough to ask the questions so that, she feels that someone actually cares and then refer on. So where to refer? I know I'm running over time. I would start, so if you have a woman where there's ambivalence or other complexities and she is wanting further support, such as counselling, 1-800 My Options, as I said, will assist women to find and pregnant people to find a pro-choice counsellor. There isn't a statewide publicly funded pro-choice counselling service, so for women on low incomes, it can be difficult to know where to go. some of the counsellors listed on 1800 My Options will have various Medicare rebates. Melbourne Pregnancy Counsellors, we're based in Coburg and Eltham, but we do a lot of telehealth. So, you know, I see women all around the country now. There's 4 of us. We've all worked in this sector for about 20 years. We refer to each other if we're booked out. We do telehealth and some face-to-face. I just thought I'd put in there, Murray Stokes offers some free phone counselling, pregnancy options, if they're, it's just double check that one because it can be really hard to get into.
Great, thank you, Trish. Just going to keep us on time if that's okay.
Yeah, that's fine.
We will make sure that we send these slides out to all of the participants today, and we'll also share your contact details of all the presenters so we can keep the conversation going. All right, thank you, Trish. It's my pleasure to now introduce Dr. Paddy Moore, the Clinical Lead of Abortion and Contraceptive Services and the Clinical Champions Project at the Royal Women's Hospital, as well as Dr. Linda Rose Chapayama, a local Melbourne GP and a GP at Clinic 66. So thank you, I'll pass over to you.
Hello all, and thank you very much for this opportunity. We've just turned on our video but can't see if it's working, so if somebody wants, oh yes it is, thank you very much. Again, thank you very much for this opportunity, and I also wanted to start the talk that I'm giving also with my colleague Linda Rose Chapayama, whom I've met recently and have really enjoyed working on presenting this together. We would like to acknowledge the traditional owners of the land from which we are broadcasting from tonight, elders past and present, and to acknowledge that this land has never been ceded. And to just acknowledge also that the history of disenfranchisement and marginalisation is played out large in reproductive and sexual health inequalities, and that's what we're addressing this evening. So I'd like to begin with just a little overview of what we're talking about. And we're talking tonight about medication. Oh, Kathy, you've just obscured my... Sorry. My lovely assistant here is obscuring this thing. Yeah, so we're going to talk tonight about medication termination of pregnancy, because that's the option that can be rolled out in primary care. But inevitably, we do talk about the provision of surgical abortion, and the if I could just say straight up that the assumption is that the ideal service or the ideal suite of services offered in any LGA would have choice as their basis. But that's not the reality at the moment. I've deliberately put this photo here of 2 young women who I would just like you to think of as the clinicians of the future. So this is the level of information that we want to get out there. These are 2 friends, lovers, partners, one's a doctor, one's not, who knows who they are, but there are 2 young women who are just diagnosing a pregnancy. And that's the point at which we want them to be empowered so that they know where to go next, whatever their decision is, or whether they want counselling, and that they would know where to get good, reliable branded information, which is what the whole project of decentralisation and services like 1800 My Options is all about. It's also to remind me to say to you that this is a time-sensitive procedure, particularly early medical abortion, which needs to be within our jurisdiction performed before 9 completed weeks of pregnancy. So at the point of diagnosis of pregnancy, the clock starts ticking, and women and pregnant people need to know where to go next. We'll talk tonight about some of the myths and legends that surround the abortion pill, as it was called when the many attempts were made to block its introduction into Australia. We'll talk about the key elements in delivery of care, a possible framework for GPs, and Linda is going to illustrate a lot of the points by taking you through a Monday afternoon in her clinic, and so that you'll see exactly how this rolls out. We'll talk about resources, opportunities and challenges, and hoping at the end that there'll be time for a question and answer session. And if we could just briefly talk about some of the myths and legends, and I'm not going to go into them all at the moment, but I'm hoping that, and I believe that our presentation will deliver the answers to most of these. Some of you may remember the politics that swirled around our media when we tried to get medical abortion available in the 90s, and we didn't really get it successfully, and certainly didn't get it floated on the PBS until 2015, that it was the most dangerous drug, the murder pill it was called, that it needs special monitoring because it's so deadly. And just I'd like you to think for one moment about the special monitoring that's required for Viagra. Pharmacists won't stock it. There's a high rate of failure. Many women hemorrhage and need surgery anyway. It's something that has been often presented even by my colleagues. There have been many deaths overseas. We're forcing women to undergo a traumatic experience. And we have heard from Trish tonight that some women do experience it as quite traumatic, and both Linda and I will address the need for a sensitive inquiry and screening about who might be a candidate for thinking about a surgical rather than a medical. One that really gets up my nose is that women will somehow find this such an easy procedure that they'll use it instead of contraception. Silly women. Look, it's up to them to decide what they're going to use. And hopefully by the end of the presentation this afternoon or this evening, you'll have an appreciation that one of the central tenets of supplying and decentralizing early medical abortion is to empower women and pregnant people so that they can make the choice that suits them. I hope that I believe that we will inform you that this is not a highly risky procedure for the practitioner to engage in. When it first was floated that GPs and primary care could deliver early medical abortion, it initially affected some of the insurance premiums, but each and every medical insurance body has now sorted that out, and it doesn't increase your insurance premiums. It's not regarded as a procedure as you know, removing warts or moles, etc. So it's a non-procedural. That the practice might get targeted for adverse attention, and one of the things that we have learnt, and it has been a great source of comfort to practitioners thinking about engaging in providing it within their primary care setting, is that in fact they haven't been targeted for adverse attention. And that's one of the things that embedding it in general practice actually makes it invisible. One of the things I always say that when I go out to the regions with Kath is that I'm very aware that I'm a practitioner in a huge big hospital, and when I walk into work in the morning, I'm unidentifiable. No one knows if I am going to be the IVF doctor or the cancer doctor or a doctor at all. They don't know. A lot of GPs in small areas feel that they will be identified. But in fact, the reverse is the case. Because it's embedded in general practice, they don't, nobody knows what the patients in the waiting room are there for. The worry from some practitioners has been there hasn't been any clinical support available. And one of the big things that this program is about is providing such clinical support, taking it a step above just becoming a prescriber, which is an online learning tool, and taking it a lot more so that we have interactive evenings and communities of practice. And towards the end of our presentation, my colleague Kath will explain to you all the various online and other formats of community of practice that you can engage in. And it's that sort of critical mass of just being able to discuss patients and patients' experience with other colleagues really, really helps. And another concern that hasn't been borne out is that the local hospitals will not be supportive and will turn away our patients. We've had several examples of where we've had to facilitate support and illustrate the concept of duty of care to some regional hospitals, but each and every time their Board of Administrators have supported that. And it's really about making the pathways possible. So if you could advance. So I think we've mentioned before that ideally surgical or medical, whether a person decided that would be dependent on the gestational age and their personal choice, plus or minus some not very commonly problematic medical issues. So personal preference about the method, the length of the procedure, the number of appointments that might be needed, and we would be the first to acknowledge that it is a more time-consuming process and requires more concerted follow-up than a surgical. Contraception cannot always be provided immediately, although we will reassure you that a contraceptive plan can be delivered in a timely manner for all patients. There are a few medical indications, such as those patients on blood thinners who really should not be having a miscarriage in an unsupervised manner. But there aren't very many other negative indicators. Someone who's on high-dose steroids, it just won't work for them rather than it being a contraindication. But really, a patient's concern about confidentiality might in fact mean that even if there was a service available near them, they might choose to go to a different centre for confidentiality reasons. So this is all about empowering rather than forcing people to do the only thing that's available. And I just wanted to get you to consider that factor will inevitably see a final settling. If we did have pure choice LGAs, that we wouldn't probably see a complete tipping towards early medical abortion. The countries that have adopted it and adopted it very, I'm thinking about the Northern European countries. I visited the NHS and saw the figures for the NHS, is because they haven't got choice. So 68 to 70% of women in the NHS now have a medical abortion, but that doesn't necessarily reflect what their first choice would have been. So the modelling, the mathematical modelling is sitting at probably about 30% of women if they lived in an ideal situation at this point with the cultural and social environment. Sorry, I've got a tickle in my throat. That we live in Australia would probably sit at about 30% choosing, but that has a huge implication for access. And medical abortion certainly is a much more democratic, has a much more democratic potential than surgical abortion in terms of who can access it. Next slide, please. Yeah, I'll just have another week. And we'll advance from this one because it's not quite so relevant for this evening's one. And now I will get rid of this cough while Linda takes over, perfect timing, and talks about her Monday afternoon in clinic. Thanks, Linda.
Thank you, Patty. Hello, everyone. Okay, so I find that when thinking about medical abortion, it's quite can feel quite daunting when you're not quite sure what you would do in your own clinic and where you'd start. So I'd like to just kind of walk us through a very typical scenario for me at the moment. I'm lucky in that I'm still fairly new in the practice I'm working at here in Melbourne, so my appointment book isn't overflowing. If you're in that scenario where you're possibly booked out 6 weeks in advance, it can make this a little more difficult and possibly have to kind of think about how bookings might happen. But we'll go through and talk about my patient. So it's a late Monday afternoon, you're tired, you're probably hungry, it's been a very long day. 20-year-old female's booked as a new patient. Thankfully, she's booked into a 30-minute time slot because that's the standard in your practice from any new patient. When you look at the file initially in her intake form, it seems fairly uncomplicated. She's noticed she doesn't have any allergies, she doesn't take any regular medication, and notes that she doesn't have any significant medical history. We come in, we do our initial introductions, and you use whatever line you usually use. How can I help you today? What are you here for today? Mudiwa, who is the 28-year-old woman in your room, stops talking in her normal voice and starts to whisper in a bit of a hush. I'm pregnant. I don't want to be. I called 1-800 my options, and they said you can help me. Now, this can possibly be a heart sink moment for you. So I'd like to take us through how you can turn that around to be an actually positive opening line in your practice. Okay, so I thought it was a good idea, rather than work through the clinical scenario again, to go backwards and say what it is you would need to have done to be able to hear that line and hopefully almost move into almost a bit of an autopilot in terms of the things you know you need to achieve. 30 minutes isn't a very long time. You could easily spend 45 minutes to an hour with this patient. But if you've got a plan in your head and a routine, you can get through the essential clinical parts fairly quickly, but then also actually be able to then actually support your patient. Spend some time talking, counselling and listening. So the first step is you need to be registered and legally able to prescribe a medication that can help this woman if she does want to proceed with an early medical termination. The MS two-step website is the current portal, which we all have to use as doctors in Australia. Our ONG colleagues can simply register without doing the training, but the training is quite useful, I think, for everyone in terms of understanding the framework and the process. Once you've done your initial training, there is a quiz at the end, and then you're issued a certificate and you are now a prescriber. You do have to go through and do a refresher module, which is a lot shorter, every 3 years after that. You don't have to do it all at once. I think the website says 2 to 3 hours is the average length of time. Now, I think most GPs, in particular, a lot of women GPs who do a lot of women's health and a lot of mental health, particularly in the last 2 years, you've already got a lot of really good counselling and supportive skills under your belt. I find sometimes as GPs, we underestimate just how much, just the level of our skills that we all have already. The RSC GP does have a pregnancy choices training module that's available via GP training. That's a technical issue. It will allow you to bill item 4001. Trish did mention the item number that a social worker would use, but 4001 is the GP equivalent of non-directive pregnancy counselling. The training itself is a little bit formulaic. It almost feels like a bit of a box ticking exercise. But it allows you to register with Medicare to be able to bill this specific item number. As GPs, we all know the pressures, particularly if you're considering a low cost or bulk billed option for women, and having that training under your belt allows you to be able to mix and match some of the item numbers you might want to use. I do want to point out that I recommend, if you're wanting to do non-directive pregnancy counselling, good to sort of look online and find other issues and other resources that can really give you a really good base. And of course, as Trish has already mentioned, there's always a lot of other really good options to refer to pregnancy-specific counsellors as well. I do recommend you contact your defence organisation. With discussion with colleagues, I know that the ones I've listed there, Avant, MDA National and Tego, definitely do offer cover for you doing medical termination in your clinic or online as well via telehealth, and it's a non-procedural cover, so it doesn't increase your indemnity costs. Really good idea to be quite comfortable with PRODA as well. Hopefully a lot of us are now using that anyway to be able to get our authorities very quickly. MS two-step is an authority prescription. If you issue that without the authority number, I think it averages $350 to $380 at a chemist for a patient. I have had scenarios where a patient wants it not there because they're afraid someone might check their My Health record, but it is important to remember that it's got to be authority, and PRODA is the quickest way to do that. As my colleagues tonight have already mentioned, it is important to establish a community support around you. Talk to your practice colleagues if you're going to be thinking about doing this. Find like-minded GPs, catch up support. There's a fantastic Facebook group for anyone who's still online doing that. And then, yeah, Proto again, just mentioning that again, really important to be comfortable prescribing. Slide, please. Okay, so another thing I did, so when I moved to the clinic I'm working at most recently was the end of last year. I searched the MS two-step website as a prescriber, put in the postcode and try to find pharmacies that were as close to me as possible. I called up, I introduced myself to the pharmacist, discussed that I'd be offering medical termination in the rooms, and needed to talk through this. So the idea of pharmacies not ordering it, it is an expensive medication for them to lay out. As I said, full cost is around the $380. And ordering that in, they do want to have some sense that they're actually going to be able to dispense the medication. If they've got a prescriber in their area, it's going to motivate them to do that, to hopefully have a box in the back at least, or someone who might need it urgently, or even discuss with their supplier. So if they ring in the morning for an MS two-step box, it might arrive later that day at clinic. As others have already mentioned, this is time sensitive, and a lot of times you don't want someone who's 8 weeks and 5 days pregnant being told they need to wait 3 or 4 days to get medication in your local area when it could actually be too late. I also discussed with the chemist actually ordering a box of Cytotec or the misoprostol, which is part of the MS two-step. A pack of 120 tablets is available on private script. And that's useful if people have had a lot of vomiting and they may need to go and pick up some extra tablets. It can be used if they have retained products. And again, not a medication that pharmacies will necessarily always have access to, but if you speak to them, they can then organise themselves as well. With my pharmacist, I also talked about, the preferred contraception options that I discussed with my patients. LARCs are excellent, having Mirenas, Kylenas, copper IUDs, if they can get them, if you're an inserter. And my favorite oral contraceptive at the moment is the new progesterone only, Slinda, it's called. Fantastic. And again, something they may not necessarily have available. Location and access to imaging. So imaging is essential. You're going to be able to confirm dating for the pregnancy and also exclude possibilities of things like ectopic pregnancy. Having a decent relationship with providers near you. Know if it's possible to get scans reduced, gapped or buck-billed. If you ring up and they hear your name, are they going to understand that it might actually be an urgent scan that's needed? Where I work, a lot of women report that sometimes they ring and they're told it's a 2 to 3 week wait at a few of the imaging providers for a pregnancy scan. When you've spoken with the service and they know that you're not needing a detailed scan, it really is just about dating and excluding ectopic. They're often more comfortable to fit them in as urgents because they know they can do it fairly quickly. So you've kind of set yourself up with an imaging provider, someone who can dispense the medication. Good idea to talk to your colleagues. So follow-up can be difficult, particularly if you don't work 4 or 5 days a week or you're going to be having leave. Reminding everyone that a doctor who prescribes contraception does antenatal care, looks after women in that postpartum period. You already have all the skills you need to be able to manage possible complications of a medical termination. Like I already said, you're probably actually already really good at a lot of this counselling. So coordinating with your colleagues, even if they choose to not be prescriber, knowing that when you're not there on a Wednesday afternoon, if they see Dr. Sandy or Dr. Amanda, they're going to get appropriate care, the follow-up will be appropriate. It means that you can relax a little bit and not be too stressed about who you're seeing. If your practice nurses have an interest in sexual or reproductive health, some are possibly trained midwives even or worked on wards previously, they're going to be an excellent resource. They can pick up the phone and speak with your patient, answer their questions when you're busy. Now, reception, absolutely essential. It needs to be very clear with your reception team that these need to always be double appointments. There's no way you're going to do this properly rushing through it. Patients need to be aware when they ring and say they're wanting to talk about an unplanned pregnancy, letting them know that at least 3 appointments would be needed for appropriate care and follow-up. And also for the team, just remind them this is just a normal procedure in practice. Let patients know it's long appointments, at least 3 appointments needed. And also make yourself available. If you are booked out, but you have capacity to fit people in or do telehealth or talk to the nurse, just empower your team to be able to speak to you, send you a message and go, someone's on the phone, they sound pretty desperate, what can we do for them? Okay, next slide. All right, so back to our consult room. We've done all that preparation. We've got our systems in place in our clinic and in our community. So in terms of what you need to find out, you do need a good detailed menstrual and pregnancy history. Has she had ectopics in the past? What was the first day of her last period? What's your likely dating? Again, coming back to that time issue, you've got 9 weeks or 63 days in order to be able to prescribe this legally in community. If you've got someone who's only 4 weeks pregnant, possibly, and has a regular period and that's quite reliable, you can take the pressure off a little bit, maybe talk about a bit more counselling, refer for that. If you've got someone who knows what they want to do and they're 7 weeks and 5 days, you've kind of got to get, you know, everything in gear if they've come to you without any investigations. Now, just your normal GP work again. What are their pregnancy symptoms at the moment? Do they need some nausea medication while we work through this? A lot of young women I've seen seem to think they've got to suffer through what they're going through until the pregnancy ends. Have they got pain? Have they got back pain? How would you normally approach someone who comes in pregnant? What are the questions you'd normally ask? Now, safety is just core, isn't it? So as others already mentioned, you know, cultural considerations. Is there domestic violence? Is there coercion? Have they got a support person? I often say to my patients, your support person can be someone home with you. It can be someone who's going to text you on the days you take medication to check in and just see. And always a good idea to have that early introduction about your long-acting reversible contraception. Just start signposting it. So as you go through the process, you're able to talk through them. Now, investigations, really quite important. Again, I would order an HB, a ferritin, and the quantitative beta-HCG. Now, a lot of guidelines will still say to you that a blood group and antibodies are absolutely essential to order. There was a lot of movement, particularly in the pandemic, that showed that even women with a negative blood group doing an early medical termination don't actually need anti-D treatment. So it's interesting, every once in a while I get a few patients who come and go, I have a negative blood group, I've looked online, I know I'll need anti-D. And kind of talk to them and say, well, no, we've moved ahead, we haven't done that. If someone had traumatic bleeding though in the past, or issues of miscarriage, you may want to consider that. And reaching out to your local hospitals to see about access to anti-D may still be an option, but it's not something I still order as standard. Always important to do your STI screening, excellent opportunity. I find that now we're only doing cervical screens every 5 years. I feel like we've got that little less access to women or people who might become pregnant. So it's an excellent opportunity to sort of do that screening as well. And then your early pregnancy ultrasound. So reminding you again, you're not wanting a lot of detail necessarily on your scan. I've just popped there on the slide the actual wording that I use. I've got it as a shortcut. So I copy and paste it, print it, send it to my patient. I'm not having to kind of type it out every single time. I always check with the patient if they're okay with me putting pre-medical termination on that form. Some people may feel uncomfortable with that. Again, when you've spoken to your imaging provider, you're going to get a feel about, how a patient may be, the experience they may have when they go for a scan. So I often refer and recommend places where I know my previous patients have had a good experience, where there's no judgment. It is just basic. No one turns on the camera. No one, turns on the sound, so they have to hear a heartbeat if there is one. And then you need to discuss the medications they're going to be needing to take. So the MS2 step itself, which is your composite pack, the mifepristone, misoprostol, but really important to talk about analgesia. So again, in your basic history, is there allergies? Is there issues with codeine? Is there issues with medications like endone? An antiemetic is going to be really good. And then again, medication around, again, talking about contraceptions and the options and choices they'll have there. Okay, I think we'll go back to Patty now. Thank you.
Thank you, Linda. And I would just like to comment on, I really, really liked what you said and wanted to back it up, that those doctors already, and nurses and practice nurses and nurse practitioners already providing women's health and sexual and reproductive health have got all the skills that they need. A lot of people get hung up on, I have to become a prescriber. Look, it's a little formulaic, the way that we have to become a prescriber, and it doesn't, as you also eloquently pointed out, it doesn't really tell you all the things you have to do. The things that you have to do to make it work are all those conversations, setting it up so that in your local community, you know who your go-to people are at the ultrasound provider, and who the chemist is, and what their attitude is, and how many they're going to stock, and how many they expect that you will be prescribing per week or per month. I thought I would give you a little bit of detail about the drugs involved. So mifepristone, what is it? So mifepristone is the first drug in the two-step packet. So Marie Stopes International is the drug company part of Marie Stopes, and they are the sole provider in Australia of this medication. And they have developed it in a really good way in a little two steps. So you take step one, then you take step two. It's visually very easy to read. Step one is mifepristone, step two is miso. Mifepristone, which is taken on or around the day of the first interaction with your patient, was developed in France in the 80s. It was known as RU486 then. That was its laboratory number. So that some of you will be aware of that. It's been called RU486. How it works is it's an anti-progestogen. So it works on the progesterone receptors and blocks them. But this is a very important understanding, that it works on the progesterone receptors in the endometrium only. There are progesterone receptors within the tube, within the fimbria, within the cervix, and within scars of cesarean sections. But it doesn't work as an anti-progestogen in any of those cases. So it works only on the progesterone receptors and blocks them in the endometrium. So it's got to be an intrauterine pregnancy. This is not a treatment for ectopic pregnancy. On its own, mifepristone was observed to induce abortions in 60% of the pregnancies in which it was used. This was a devastating result. 60% efficacy is not going to make it with any drug. I wouldn't take an antibiotic that had 60% efficacy. So there was a while there in the early 90s when it was really concerning about whether this was going to be a useful medication. But in combination with misoprostol, which is a prostaglandin, which is taken as step 2, and so mifepristone is 1 tablet, and step 2 is several tablets of misoprostol. Misoprostol will induce the miscarriage by increasing contractility of the uterine body and increased dilation of and encouraged dilation of the cervix. So really, that's the part when they start to miscarry. But what the mifepristone does is it stops or terminates the pregnancy. So if you block the progestogen, the pregnancy stops, and that usually happens within 24 hours. You could advance now, thanks. Just so that we demystify mifepristone, it has many uses, and overseas it has a lot more uses than it has in Australia. In Australia, it's only licensed for use in early medical abortion up to 9 weeks in primary care. And it's also licensed within the hospital for providers such as myself, obstetricians and gynecologists, either to help with softening the cervix before an advanced gestational surgical abortion, or to help in the management of fetal death in utero or advanced gestational late abortion care. But that's not how it's licensed for use in general practice, and that's very important. But overseas, it's used as an emergency contraception. It's used to induce menses for quite a number of in quite a number of countries. And to give you an example of that, in France, you can purchase mifepristone from the general department stores like Galeries Lafayette, etc., and use it if your period is 1 day overdue. So that's probably a little bit of a career nirvana for me, to think that we might have patients who would not be able to do that at some point. But that is not how it's available here. It's used to induce menses in those women who haven't got regular periods, in the same way as we would use a progesterone challenge test, where we give 10 days of progesterone and then withdraw it. That is, a lot of you would already be aware, causes a lot of unpleasant side effects, particularly in young adolescent patients, whereas mifepristone is much better tolerated. So this is to illustrate that other countries are not, or never have been, as frightened of mifepristone as we have in Australia. And while that might be a source of annoyance, it also can be understood that because we were very slow and late in adopting, that we had 25 years of research, 25 years of safety research before we actually started prescribing it here. And as Linda mentioned, we also now have the pandemic and the research that went on by providers of abortion care in the NHS, Northern Europe, and also in America, where they relaxed some of the guidelines, particularly the group in Canada. So relaxed the use of needing to prescribe anti-D, and relax some other contingencies around beta-HCG testing, and find that their safety data was still really, really good. So no need to be frightened of this drug. Can you advance, please? Why it's rolled out the way it is in Australia is a legislative issue, and it's political. And if you hadn't got the message that abortion is political by now, have a wee look at what's happening over in the United States of anarchy. Mifepristone is eligible for prescription in Australia on the PBS if it's less than 93 days or 9 completed weeks gestation. The TGA proves it up to this. During the pandemic, several rural clinicians started using it up to 10 weeks. So the patients between 9 and 10 weeks had to pay for it off-label. But on-label and for the price of a script, it has to be up to 9 weeks. The cost at private clinics seems to sit at around about, or sometimes slightly greater than that for a surgical termination. And one of the challenges and perhaps gauntlets that I would throw down for the discussion part is that there's no need for that. It could be supplied for the cost of a script, but it leaves it up to the primary care and practice to determine what they would charge, whether they would bulk bill. Certainly within community practices where they have access to bulk billing the interaction, and then also getting a bulk billed ultrasound, they can provide this at a much more affordable cost. Can you just, I'll just do the contraindications. So the things that are very important to make sure that aren't a current issue is make sure the patient doesn't have a bleeding disorder, which has either been diagnosed or is in the process of having diagnostic tests done. It's important to exclude an ectopic pregnancy. Adrenal failure is listed as a contraindication. That's because those patients would be on oral or enteric corticosteroids. And if they're corticosteroid dependent, that will block the receptors. No one's allowed to do anything if they've got porphyria. And having a medical abortion is another thing that might trigger a porphyria episode. Much more commonly, if there's an Iucd in place, it is not appropriate to proceed with the medical abortion until the Iucd is removed. Hypertension, cardiac problems, hepatic or liver disease are relative contraindications, and anemia is important to screen for. I noticed that Linda said she does a hemoglobin on everyone. Our practice would probably be to do it on at-risk or symptomatic patients, but you can decide with regard to the screening you would do depending on the population that you serve. Could you proceed, thanks? I think this is you, Linda. Is this your second consultation? Yeah, so
we're back. Okay, so you've done your first consultation, you're aware of all the medication issues, and your patient returns. Hopefully you've had the opportunity to review your results. Luckily for you in this scenario, Mudiwa is the perfect patient. She's got a normal ferritin, normal hemoglobin, and her beta-HCG correlates with the dates that she'd given you. The pregnancy is interuterine, a yolk sac is seen, and the dating is approximately 6 weeks and 1 day. Okay, so now we move on to actually what we're going to be telling this patient and what they need to do. Again, this can be quite time consuming. What I found in face-to-face clinic, having written instructions that you can actually either have emailed to your patient or have there in front of you to take them through it, makes it a lot easier, and they've got something to refer to. MS Two-Step or Mary Stopes International themselves do produce a booklet that you can order copies of and hand to your patients. But I find that each practitioner will probably counsel slightly differently. And this is the way I speak to my patients around what they're going to need to do. So a really important thing when you're talking to them is to remind them that this is a two-step process. The name MS Two-Step is not very inventive, but it is actually very instructive. A lot of my patients turn up thinking they're going to take all their medication on 1 day, it will all be over with, and Bob's your uncle. So step one, I find that taking that tablet, which is the single mifepristone tablet, in the evening is going to be quite useful. Good idea to have an antiemetic before, because that progesterone blocker can make nausea a lot worse. And if you've already got someone who's got that nausea of early pregnancy, we don't want them to then vomit up their mifepristone. If that happens soon after taking it and they haven't absorbed enough, your medical termination is not going to be successful. Now, the gap between step 1 and step 2 in the process needs to be a minimum of 24 hours up to 48 hours. We find that the gap of 36 to 48 hours works quite well, but depending on your patient's circumstances, you might need to reduce that down a little bit. But I find that as long as they understand it's an absolute minimum of 24 hours and then that maximum of 48 hours. Now, I talk to my patients about it's always easier to get help at 3 o'clock in the afternoon rather than 3 o'clock in the morning, no matter where you are. So considering that this process on day 2 might take a good 5 to 6 hours of fairly intense symptoms, it's a good idea to take your tablets on the second day in the morning. Every once in a while, I have a patient insists on taking it before bed, and we've got to respect our patient's autonomy, but I think it is important to sort of give them a good idea of what may happen at the sort of extremes of the situation. Then that way, if they have a really good experience that, that didn't need any extra help, that's great, but you want to have them as prepared as possible. So I have there about taking some pre-medication. So antiemetic, I've got Zofran there, pain relief. I normally prescribe Panadeine Forte and get them to pick up a box of Naprogesic. You might want to switch that out for Endone or Tramadol for your strong analgesic. They may have allergies to non-steroidals. Obviously, you're going to be talking to your patient and changing that. A light breakfast, a light meal with your pre-medications at least an hour before you're going to be doing your second step. Now, the second step is that misoprostol. The important thing for patients to understand is the tablets need to be put buccally and sublingually, and you need to allow them to dissolve. I remind my patients that that's really important. We want the medication to be absorbed via mucous membranes and go directly to the bloodstream. If you swallow 4 misoprostol tablets, you're probably going to throw them all up pretty soon after. It can induce that. Also, a good heads up, these are fairly large tablets. They can be used orally, buccally, but also PV in situations. They're not like a Zofran or a Danzatron wafer that's made to dissolve very quickly. So I warn my patients and say it could be a good 20 to 30 minutes of these tablets being in your mouth. Take your pre-meds, be set up, ready to go, and be aware that it may take that long. Okay. Now, I've had some patients who tell me they pop the misoprostol you know, in their mouth is directed, and within 20 minutes, they're passing just what they describe to me and identify as a gestational sac. They're bleeding, they're cramping, they're basically going through to have the actual termination itself. Some women, it could be 2 to 4 hours of nothingness and nothing happening. So being set up somewhere where they're comfortable, home environment preferably, where they're safe, we've kind of talked about that, and that support person availability. If someone has a very large bleed very quickly, they could faint, they could fall over, hit their head. I always speak particularly for women or people who have young children in the home. Who's there to help? Can someone take them away? Have you thought about the safety of basically discussing what procedure you're having with people? I've had some people who ring a cousin and say, I'm not feeling well, I need you to ring me at midday on Saturday. Can you please, you know, just check in on me without much more detail? So there are ways around this to be able to have support, but it is important. A lot of pregnant people, I find, do want a fair bit of privacy around this. Can be very deeply personal, possibly emotional, and having other children in the home or even a partner can almost be triggering for them. So I kind of encourage them and support them to decide how to go there. So with that example, I often say to patients, Thursday night for step 1, Saturday morning for step 2 with those timings. Give yourself a good 36-hour gap. Obviously, that may be modified depending on a person's schedule, when their nominal weekend is, and so on. I print out and have on that instruction sheet that MS2 step 24-hour support line. It's staffed by registered nurses. There are a few steps and press buttons to do. But if someone's not quite sure if it's drastic, if they need urgent help, they can ring that line, speak to a registered nurse who supports women and get some help. Next slide, please. Okay, so I also produce, again, this is just a pro forma of what I have saved. And again, having all these saved as your shortcuts, as your performers, letters in your practice software is going to make a lot of this a lot easier. Things that will auto-populate, you can go in and change and update any bits you need. But this is the letter that I use for patients who find that they are needing to go in and get care. Out of hours, weekends, if they're very unwell, if someone's got to call an ambulance for them, having it on their phone and possibly a printed copy. Again, I think demystifying the idea that our hospital colleagues are not going to be interested in supporting us, are going to be frustrated with these patients. Doing this in clinic and online, I'm yet to hear of a very bad experience for patients where it's kind of reproducible at a clinic. Obviously, you're sometimes going to find a clinician where someone has a bad experience. We can't stop all of that. But this is basically a handover. I tell the patients, you don't have to turn up a triage and give your whole life story out loud with a packed waiting room around you. If you print this off and hand it to the triage nurse, hopefully, again, with their training, they're going to be able to look at that really quickly, understand what's going on. And if someone's, you know, had a syncope, if they look really pale, if they're in a lot of pain, hopefully they can then be triaged appropriately. The most common things we find is needing more analgesia if the meds you've given aren't effective, or as I said, if someone's actually had a syncope from a very sudden big gush of blood at home, they may then need an IV line and fluids. And again, demystifying that for patients. So this is normal care. If you're going into hospital because you have pain or because you've had a faint or you're bleeding heavily, there is care available. And this, I think, kind of supports care. And I do ask always at the bottom that they can let me know as their primary care provider if they've turned up. Hopefully you get a discharge summary. And that's what I hand my patients. So I'm interested to hear from Patty or any other of our colleagues who may be on the receiving end of some of these letters, if that's appropriate or if there's changes she'd recommend. And I'm happy to send those performers out at the end of this so people can take what I use, modify it and make it appropriate for your own clinical scenarios. Okay, all right, thank you.
We forgot to unmute. I'm very sorry. I just wanted to jump straight in there and say, no, that's great. And it's really similar to the a two-sided page that we developed that we're also happy to share, where one side is for the patient, what to look for, you know, what's too much bleeding, what's too much pain, how long should it go on for, and on the reverse are sort of some softly directive guidance to the staff in the emergency departments. And the feedback is that they find it helpful, and they find that the patients, so I can only go by the feedback in my hospital, sorry, Linda, but they find that the patients are better informed and tend to come when appropriate, and call for support through the MS helpline is really well utilised now, and the nursing staff on the MS2 helpline, which is available to anyone going through this, are actually really appropriate. They don't just reflexly tell everybody to go to hospital. I'm aware of the time, and so the only reason I put this up is to say that the regime that we have got in Australia is based on our legislation. There are lots of different other regimes, and you'll notice right across the top that the dose of mifepristone has changed quite a bit. So the original French dose was much higher than what we have nowadays, and what we are prescribing, the 200 milligrams, is the one that research and evidence has shown to have the greatest efficacy with the least side effects. There's very few side effects from Miffy, but you don't need 600 milligrams. So the TGA validated one in Australia. Don't look at the Lancet, which might publish one from the UK. The methodology of becoming a prescriber has got the prescribing parameters, and advance. And just let's finish with success rates, okay? And then we'll open it for other discussion. So a 93 to 98% success rate using early medical abortion up to 9 weeks. The data from overseas up to 13 weeks in Canada is that it sits at around 95%, leading to a complete abortion. In the remainder, curettage may be necessary to evacuate the uterus, but this is a key learning point. Expectant management of possible retained products of conception is appropriate for up to 2 weeks. When EMA is introduced into an institution like the Women's, or a practice like CoHealth, for example, when it's initially brought in, there's a bit of anxiety about the possibility of retained products, and the curette rate is higher than it needs to be. And as practitioners become more confident, and the emergency departments become better at managing it, and the on-call gynecologists are more familiar with it, the curettage rate goes down. And that's also supported by the research that Mari Stopes did when they published on their first 5,000 scripts. So don't do ultrasounds on everyone who talks about having bleeding around about 7 days or plus. Go by the symptoms and the fall in the beta HCG that you would organise at the follow-up. And we can go into that in a little bit more detail. We've already talked about preparing our patients for the side effects of the abortion process, and also acknowledge, this slide is about acknowledging that nausea, vomiting, diarrhea and pain and chills can be part of the side effect profile, but many of those are also part of pregnancy. Advance. And Linda, if you wanted to
yeah, so just going through again. So luckily for us, Madiwa is the perfect patient. I've mentioned they're doing a beta HCG day 7 after mifepristone. I'd like to just say that that's not necessarily an essential thing to do. Some protocols that you'll see will have women simply doing a urine pregnancy test 4 weeks after their medical termination if the clinical course fits what we expect. Again, something to probably think about in your practice and decide what you'll do. Madiwa's come with her husband today. She's here when going to her husband. And I just wanted to make that the case, just again, to demystify this. Those sorts of myths and legends of the young woman using this as contraception, irresponsible, you know, back and forth with services. Often these patients are partnered. They may or may not have other children, but this was just not the good time for this specific pregnancy to proceed for a multitude of reasons. If you're an IUD inserter, 14 days after is an appropriate time if things are appropriate to insert for contraception. And I'd like to remind again that there may be a need to kind of talk to pregnancy counsellors or other therapists. For this patient, it was about wanting to talk about what may happen in a future pregnancy, even though she was happy with this. And just that third consultation to wrap around care of your patient, make sure they're well physically, review any results, and also plan, prescribe, or insert their contraception. And with any luck, they may even become a regular patient of yours, or they may have only wanted you for this episodic care and return to their standard usual clinic, whatever's going to suit that patient as you support them through their early medical abortion. Thank you.
Thank you, Linda.
I think we're at 8 o'clock, so we could stop there and return later for questions and answers.
Yes, we will have time for some Q&A. I just wanted to see, Kath, if you wanted to touch on the Clinical Champions project before we go into the Q&A.
Sure, that'd be good to talk.
Great.
Yep, there we are. That's the title. So just the next slide, I just wanted to talk about the Clinical Champion project, which is a statewide project based at the Women's. I'm the project worker and the clinical lead is Patty. And the purpose of the Clinical Champion project is broadly to support access and equity to abortion and contraception services. And probably the biggest component of our project is around supporting the workforce, such as who are in the audience tonight, to provide things like evidence-based resources such as clinical guidelines, that our early medical abortion webpage, and just today, hot off the press, we have released our early medical abortion e-module. And these are all available on the Royal Women's Hospital website. I'll post the link in the chat, but we will also put together a resource list and send it round to everyone who's registered for tonight. So they're all freely accessible. The early medical abortion e-module is, as I say, is accessible on our website. It's hosted by Women's Health Victoria, and it is also free. And it's designed to sit alongside the MS two-step training module that's offered by MS Health. But as we know, that's only offered to pharmacists and medical practitioners. So there's a gap for nurses and midwives and nurse practitioners and social workers. So the broader workforce who have a role in supporting and working with women and pregnant people around early medical abortion. And it's obviously it covers the clinical pathway, but there's also components of, you know, the context of medical abortion, touches on reproductive coercion and violence, and talks about the pre-assessment phase. So yeah, it is broader than the clinical aspects of care. The other activities that we're involved in around community of practice is that we partner with an organisation called SEARCH, which is Centre for Excellence in Rural Sexual Health, and 1800 My Options. And Patty's the clinical lead for a community of practice, which is a virtual meeting that occurs every quarter. We have an advisory group that picks up issues of interest in the sector. It could be a case study discussion, or it could be, you know, a component of care that's impacting on the work around abortion. And then in addition, our workforce training we have on our website. We have links to register for Implanon practical training workshops that occur every month. And there is the possibility of IUD procedure training for suitable applicants, and again the information's available on our website. And if I could just have the next slide. So that's what our web page looks like. I'll send the link to that. As you can see, the way to find it, if you didn't have the direct link, is go through health professionals, then clinical resources, and the early medical abortion webpage. We are also, I was hoping that was going to be ready for tonight, but we're in the process of just updating some of that information on there. At the minute, the e-module's not sitting there, but it will be in the next couple of days. And just the next slide, I just wanted to show you, this is the landing page for the early medical abortion module. And that's the sections there. So that's the, once you go into the module, that's what you'll see. And there's a story about a young woman who accesses care. So yeah, I'll send those clinical resources around as a separate link for people. Thank you. I'll hand it back to Sarah.
Thanks, Kath, for sharing that. I also just wanted to share that there is the AusCAPS community of practice. Again, this is online and designed to support clinicians who are providing long-acting reversible contraception and medical abortion across Australia. It's a space to connect with like-minded peers, to ask questions and discuss case studies, and members can also keep up to date with the latest evidence-based resources and training. There's almost 1,000 members made up of GPs, nurses and pharmacists at the moment, and it's free to join, and AusCAPS just wanted to pass on that they're encouraging health professionals to join, and that it's a simple two-step process that you do online. You'll just need your AHPRA number. And also just wanted to include information about health pathways. So this is an online resource written by GPs. It provides clinicians with locally agreed information about decision making at the point of care. So if you want more information about this, we will be sharing the slides out with everyone who's registered, but also if you have any questions, you can email Health Pathways Melbourne, who will be able to provide you with a bit more information. Great, so we are moving into the Q&A. If you have any questions, please pop them into the Q&A box, and Tilly will then pass these on. So if you have anything that you would like to ask any of the presenters, yeah, please go ahead now.
Thanks, Sarah. I can see one question in the chat asking whether there are prerequisites for the IUD procedure training.
I was just responding to that actually. It's a application process. Again, the link is on our webpage, and it's really just asking the background, the demographics of the person who's interested in doing IUD training, and whether they've had previous experience and what their current setup around utilising that new or refreshed skill for some people. And as you can imagine, at the Women's, we have fairly limited capacity to offer a place for external providers. Generally, they're GPs. We just have one session each week that's available, and with COVID, of course, we've had to unfortunately close that training position, so there's a bit of a waiting list.
I guess the big issue is we want to check that the provider, once trained, will be able to provide IUDs, so that they're practice managers on board, they've got a procedure room, they've got nurse assistants, they've got access to atropine. And we do have many more than just the one session each week, but one session is dedicated for GPs because we have huge commitments to training the next lot of GPs that are doing their diploma at that point. So we're aware that there's always going to be a bit of a backlog, but by offering it as well as other providers like Sexual Health Victoria, we're hoping to get more and more providers online and confident with IUD insertion. And often we find, just to answer, I think it's Ankur had asked that, your question, we find that once practitioners become quite au fait with early medical abortion prescription, they often want to be the provider of the long-acting reversible contraception at the follow-up. So it fits in very nicely.
Thanks, Patty. I've got another question here from Kate from Your Community Health. Just checking whether there are resources in languages other than English available for patients.
There are, Carolyn, you can answer this too, but Better Health Channel have a number of resources, as well as the Women's have resources on the health information page in our website. The resources that the Clinical Champions Project have produced are targeted towards clinicians, so they've been produced only in English. And we're in the process of working with our health promotion team to develop other resources, consumer-based resources, and having them translated into community languages. But you might want to comment on that too, Caroline.
Yeah, there are some resources in other languages on the Better Health channel. I've just popped the link into the chat here. There aren't a lot of resources in other languages, but we're also, you can have a look on the Health Translations Directory, and at 1-800-MY-OPTIONS, we're also compiling the resources in other languages that are specifically about sexual and reproductive health and abortion and contraception being key ones onto the 1-800 website. So they're a little bit easier for both consumers and healthcare providers to find.
Thank you. I've got another question here from Stephanie. What is the earliest that Iucd can be inserted after Mtop? Patty or Linda?
I'm happy to go with that. So, so 14 days is usually the minimum. You want bleeding to have settled for the most part. So I'd normally say to my patients 2 weeks after having a medical termination. Some patients will want to wait a little bit longer, but I do talk to them about it important getting contraception organised so you don't have a repeat unintended pregnancy before you've organised it. So 14 days is usually the mark.
And it's really about the history, isn't it? The history of, you know, passing what's probably products and then pain and bleeding settling. You don't have to wait till there's a period. You don't have to wait till the beta HCG is less than 5. You're looking, if you are tracking beta HCGs, you're looking for symptoms going away, patient feeling systemically well, and the beta HCG dropping up around about 80% or more.
Thank you. I haven't had any other questions coming in yet, but does anyone have any questions for each other on the panel?
What do you find, Linda, is the most time-consuming part of it, of that double consultation? Is it the screening or is it the explanation?
I actually find a lot of the patients I see have actually done some research.
Yeah, that's what I reckon.
They've read about it, they've come in empowered. Often I've had quite a few referrals off 1-800-MY-OPTIONS, for example. So they know what they want for the most part. It really is that counselling. It's checking in their mental health, their well-being, their safety. So that's often the bit the patient hasn't thought about. They're often aware there's a time limit, time crunch. They want their appointment. I've had people walking going, I want my tablets right now. So kind of pulling it back and really making sure that, you know, that safety stuff and well-being, I find that's the most time consuming.
There is a question's just popped up. Do we want to?
Thanks, Ankur.
Yeah.
So Ankur is a male GP in Epping, just across from the Northern Hospital, getting a lot of non-Medicare patients with unplanned or unwanted pregnancies, and has completed the MS2 step online training. Just wondering about support provided after hours, as I work mostly as an after hours GP, and about being a male GP. Any reflections on that?
So I'm wondering if our questioner is asking about support for them because they work after hours. I presume that's what it is, rather than the patients. We don't have an on-call system, and nor does Maori Stokes have an on-call system for general questions. You could call the on-call gynecology registrar at the Northern. You'd be more likely to if you rang the on-call gynecology registrar at the Women's, to have someone who's prescribed MS2 step themselves and seeing more follow-up, because you just have to be careful that you don't get someone who actually hasn't had experience with it yet and will just automatically order a curette on the spot without seeing the patient. But I would encourage you to call our service or go through the hospital switchboard or ask for clinical champions during the day, you know, to talk about the patient you saw last night and just check in if there was something. No question is too small or too large to be considered. I guess what I would also feedback from that is that it often is a concern initially, and then once you settle in with the procedures and start to hear from others or get engaged in the community of practice, that there's pattern recognition, and it either goes really smoothly or there's an obvious issue, you know, for follow-up. So it either goes really smoothly with you know, what can be quite symptomatic pain and bleeding. Most people seem to sit on the toilet and pass the products rather than see anything, and we don't demand that they produce a sac. I think that is one of those examples, Trish, you mentioned it, and you know, somebody might have been traumatized by that. I think that might have been a recommendation early on when people were rolling it out. You've got to see the products, you've got to see the products. I remember working somewhere where they sieved everything in the clinic before you were allowed to go home. We now know that the vast majority work, and most women don't have an interest in watching it, and they deal very well on the toilet. There's something about the gravity in the toilet, and they feel really much better there. So if it tends to go like that, with a good history and passing of clots, and then the pain settles and the bleeding gets less every day. Someone who's got problematic bleeding after the 2 weeks, and remember, sit on your hands for 2 weeks, or has very heavy bleeding, it's a very different scenario, and those are the group that you would advise to go to the emergency department. And again, just to emphasize that they are less than 5% of the patient load.
Thanks, Patty. I've got a few more questions coming in. What sort of time frame do you normally recommend post Mtop for commencing contraception other than an IUD?
Right away. So the pill can be started as soon as the patient feels that they've passed everything. Implanon can be inserted on the day, because we now have evidence that shows that the progesterone in Implanon takes a lot longer to get into your system than the anti-progesterone in the mifepristone. So the timing's okay. Depo-Provera, that study was never done, but more and more practitioners are giving the Depo-Provera on the day of the mifepristone, just because that's when the patient's there. But if you're going to be very to the letter of the book, you would give it when they came back and told you they'd passed the products. But the key learning would you agree, Linda, as early as possible, and don't wait for another unsupervised ovulation. Get it under control. Yeah,
absolutely. Absolutely. I've definitely put Implan on the day because I don't dispense medication from my room, but I've definitely inserted an Implan on as they're then walking across to the pharmacy to get their medication. So I'm very comfortable with that, and having counselled them appropriate as well. Just for Anko as well, I just wanted to point out to him, work in clinic, but also online with Clinic 66. And we do have male GP who do this work. Hopefully you don't feel unsupported or put off from being able to prescribe. A lot of patients will be quite happy, particularly if you're their regular GP, to still see you for this, and it works quite well. And as Patty has outlined, there is a lot of support, and issuing your scripts out of hours, knowing patients can then go get meds, can also work really well. Gives them more access, so they don't have to wait for business hours. They can come see you after work, and still get their meds. So that'd be a great option for where you are.
And also for Anko to consider perhaps the possibility of other practitioners within the clinic setting that might be providers that perhaps haven't spoken about it. So it's a way of opening up a conversation.
And although we don't know about the absolute nature of your practice, always consider the concept of task sharing. So using your nursing colleagues, some practices have got a practice nurse, many community health centres are based around that model. And so your nursing colleague can do a lot of the pre-prescription counselling, and may have greater availability at other times as well. I certainly know of a lot of models where most of their follow-up is done by the nursing colleague.
And the pre-assessment.
And the pre-assessment, yeah.
Got a couple more questions for Linda. For Linda, how do you encourage patients to attend their 2-week follow-up appointment?
Yeah.
Golden goose.
Yeah, I think this is probably another one of those myths that patients don't come back and don't follow up. So I think kind of having it at the start, making it clear that it normally is 3 appointments across a medical termination. But also I found it's also really important to respect the autonomy of our patients. A lot of patients, for them, this is very episodic. Once this is done, they may not want to see you or talk to you again. I find it really useful when I'm talking to colleagues to remind ourselves that these are not sick, unwell patients. Women of reproductive age, on average, are going to be pretty healthy, right? Minimal chronic issues, often not a lot of medication. I try to kind of list that in my case scenario. And the serious complications of medical termination, if we're worried about rupture, people being unwell, if that's happened at 2 a.m, they've probably got support and care already. So I find I don't stress too much. We do reminder systems if they don't turn up, the SMS, a phone call from my nurse and so on. But I think it's important that sometimes once you've done this with them, they want to move on. They want to go back to their regular GP. I know of a lot of patients who then go back to their doctor and say, I had a miscarriage, not wanting to talk about the fact that they've had a medical termination. So I find sometimes it's more about managing our own anxiety about this process rather than managing what's probably a really well woman who's relieved, who's moving on with her life. The chances of her being drastically unwell are slim. And, there's no need to ring her every day for the next week. She's not calling you back. She probably just doesn't want to talk to you. And I think that's okay.
And in fact, it can be harassing or traumatizing if you wanted to rehash it. And it was something that we really had to learn in our institution practice, to hands off and, stop trying to, send pigeon carriers with messages and things like that. And it's partly empowering, isn't it? Like, I asked for this, you gave it to me, end of transaction. But it is good to be able to say that, and it's good to know actually in primary care, I've heard this from lots of other providers, is that the failure to follow up is much greater in our kind of institution, or the bigger suppliers, the bigger clinics, than it is in primary care. And I think it's because they're coming back for all sorts of reasons, aren't they? Particularly in regional areas, that they don't have the same lack of follow-up.
Thank you. And we probably just have time for one more. I will ask the panelists to respond to any other questions in the chat or Q&A function while we're doing the evaluation. But a last question, also for Linda. How can practice nurses and community health nurses support this process?
Fantastic question.
And I think the others have touched on it a little bit. So I know of quite a few, when I was first starting up, having your initial counselling by nurses who are really good at taking that kind of menstrual history, doing some counselling, they can often flag the ones that are really distressed, maybe need a fit-in, particularly if you're in a setup where it might be a 6-week wait to see a GP. And some practices have decided that their nurses can then print off some of the request forms. Obviously, it's going to depend on the skill set of your nurses and what they're interested in. Some of that follow-up stuff, the person who hasn't done that blood test, the person where the ultrasound isn't there when you thought it should be. Again, as Patty said, to be mindful of not harassing and so on. And then the follow-up as well. So that kind of follow-up, catching up with them so that it's not as time pressured for the GP. You can kind of focus on your bits. I do also have some old protocols that other clinics have used. I'm really happy to share all that as well with anyone who's interested. And I think Tilly and Sarah will be sharing our contact details. It's handy to have to just read and see what other people have done and then be able to kind of transfer that to wherever you are.
And just to add to that too, Linda Rose, a plug for the early medical abortion webpage and the e-module. That on both of those forums sit the clinical guidelines for early medical abortion care, and you know, knowing that the module through MS Health is not available to nurses and midwives, that you know, these resources are designed to be accessible. Number one, they're free and they're accessible on our website, so they're accessible to anyone who with an internet connection.
Thanks, Kath. I'll pass over to Sarah.
Great, thanks, Tilly. So while the presenters are responding to any other questions in the chat, we'd really appreciate if you could take a few moments to complete some evaluation questions. Your responses will be anonymous, but it's really important that we find out from you some responses to these questions about becoming a provider and how best we can support you in providing medical abortion and other sexual and reproductive health services. So if you could grab your phones, if you have them handy, otherwise you can do this on your computer. If you go to menti.com, and at the top of the screen, there should be a box where you input the code, which is 2617-2704. And we just have a handful of questions. The first one being, what are the barriers holding you back from becoming an early medical abortion provider? Yep, the code is 2617-2704. It's just at the top of this slide, but also I'll pop it into the chat. Yep, thank you.
So I could, while you're doing this, I could respond. I saw a question which was to ONG specialists, do we prescribe anti-D? And the answer is no, we don't recommend it. Prior to the pandemic, we had been lobbying our college to get rid of the mandated necessity for anti-D in this situation, because we're really mimicking the physiology of a miscarriage, and with medical miscarriage, we don't necessarily prescribe anti-D. And so our college made a very definitive statement about that during the pandemic. And then following the British College and the NICE guidelines, we've continued that on, which is what Linda was saying. We really find it there was another additional hurdle for patients to have to go and queue up and get anti-D. And some reported some fairly negative experiences.
All right, great. We've got a good amount of responses to this question. If you have anything to pop in last minute before we move on to the next one. All right, thank you. So the next question is, has your confidence to become a provider increased following this evening session?
That's good.
You do it.
Yeah, no, just just mute it again because.
All right, might move on to the next one, Tilly. How likely are you to become an early medical abortion provider? And if you already are, I think you could put the option of extremely likely. Okay, next one. If you are considering becoming an EMA provider, how soon are you planning to become one? So if you move your finger across this sliding scale, it'll give you different options. All right, thank you. If you are seeking information about this topic, what is the best way to engage you? I think for this one, you can pop in responses into a text box and you can put in more than one thing. All right, so what are the essential resources and support that you need or that you would like to provide EMA? Great. Okay, are you clear about the referral pathways throughout the patient journey? Again, this is a sliding scale one. Great, that's the end of the evaluation. Thank you so much, everyone, for contributing to that and also for attending the session. We will be sending out some further information through the PHN that will include the slides, as well as links to different community of practices, as well as some resources, which are examples of what Dr. Linda Rose Chapiyama uses in practice with patients. So you'll be fully resourced, and we'll also share some contact information if you'd like to continue the conversation. And a big thank you to all of our presenters tonight. So lucky and glad to be working with all of you.
Oh.